This visualization shows the piezoelectric effect in action. When an electrical pulse hits a lattice of specialized crystals, they vibrate, converting that energy into high-frequency sound waves. Those waves travel through tissue, reflect back, and create the diagnostic images we rely on in obstetrics and gynecology. The clinical application of this physics begins early. Between the 6th and 8th week of gestation, the primary objective of a transvaginal scan is to confirm the embryo's intrauterine location and detect fetal cardiac activity. This rendering demonstrates how we establish an exact gestational age. By placing calipers at the longest points of the embryo, measuring the crown rump length, or CRL, we can pinpoint the timeline of the pregnancy with high precision. This early scan also identifies when development stops. If we observe a gestational sac that remains empty, lacking a yolk sac or fetal pole, we diagnose an anembryonic pregnancy, signaling non-viability. In this technical scan, we see a completely different pathology, a molar pregnancy. Notice the characteristic snowstorm pattern of the trophoblast tissue and the total absence of fetal poles. The tissue has grown abnormally into a mass of cysts. Because of these distinct early markers, this initial viability scan forms the baseline for the entire pregnancy. That single crown rump length measurement becomes the temporal anchor we use to track all future development. Once early viability is confirmed, the clinical focus shifts. Between the 11th and 14th weeks, there is a narrow window specifically optimized for screening chromosomal abnormalities, with a primary focus on the risk of Down syndrome. This ultrasound captures the critical metric for this stage, nuchal translucency. The calipers are measuring the fluid-filled space directly behind the fetal neck. An accumulation of fluid here is a primary sonographic marker for genetic risk. This diagram illustrates the necessary diagnostic algorithm. The nuchal translucency measurement alone is insufficient. It must be combined with the mother's age and specific serum markers in her blood, free beta-HCG and PAP-A. Together, these data points synthesize into a unified risk probability score. If that algorithm returns a high-risk result, we move from screening to definitive diagnosis. This illustration shows a chorionic villus sampling procedure, or trophoblast biopsy. Under continuous ultrasound guidance, a needle retrieves placental cells to map the actual fetal karyotype. At this gestational age, sonography acts as a rigorous diagnostic filter. A difference of just a few millimeters in nuchal fluid can trigger an invasive procedure and dictate the entire trajectory of prenatal care. By the 20th to 24th week, the fetus is large enough for a systematic structural audit, the Level 2 anatomy scan. The goal here is the methodical exclusion of major morphological anomalies across every organ system. In this fetal brain scan, fluid in the lateral ventricles indicates hydrocephalus. Moving to the abdomen, we differentiate an omphalocele in a sac from exposed gastroschisis. Finally, color Doppler highlights the renal system, ruling out pathologies like the polycystic kidneys shown here. The diagnostic focus now incorporates maternal anatomy. Through transvaginal measurement of the cervix, we establish a clinical predictor for the risk of preterm labor. This rendering demonstrates the pathological threshold. The cervical length here measures below 25 millimeters. You can also see funneling, where the internal opening of the cervix is beginning to dilate from the inside out. Identifying these specific markers gives the clinical team a window to intervene. Often, this means performing a cerclage, suturing the cervix closed to physically prevent premature delivery. The Level 2 scan is the definitive structural milestone of the pregnancy. Catching subtle morphological anomalies here provides the crucial lead time needed to alter maternal management and prepare for specialized neonatal care. As the pregnancy enters the 3rd trimester, the diagnostic priorities shift. The anatomical structure is largely formed, so the focus moves to monitoring the dynamic physiological reserve and survival capacity of the fetus. To quantify this, we use the biophysical profile. You can think of it as an in utero APGAR score, a real-time assessment of the baby's overall well-being. This diagram outlines the 5 clinical parameters we track. We look for continuous fetal tone, gross body movements, fetal breathing movements, heart rate reactivity, and finally, we measure the total volume of amniotic fluid. We also assess the organs sustaining the fetus. This image set breaks down the Granum scale, grading placental maturity from 0 to 3. Over time, we look for morphological changes and specific calcium deposit patterns indicating how the placenta ages. To test if that aging placenta is still functioning efficiently, we use color Doppler ultrasound to measure blood flow resistance in the umbilical artery. These waveforms reveal placental insufficiency. Waveform A shows healthy flow. As resistance increases, waveform B shows reduced end diastolic flow. In the third waveform, flow completely reverses below the baseline. This reversed end diastolic flow is a terminal red flag indicating placental failure. In a final survival response to this hypoxia, the fetus will execute the brain-sparing effect, vasodilating cranial arteries to redirect whatever oxygen remains strictly to the brain and heart, sacrificing flow to the kidneys and gut. In these late stages, morphological structure takes a back seat. The hemodynamic data from the Doppler and the physiological scores from the biophysical profile become the primary indicators that dictate exactly when to intervene and deliver the baby. Outside of obstetrics, the gynecological application of ultrasound operates differently. Instead of following a strict developmental timeline, it is symptom-driven, organized into 4 main clinical pillars: pain, bleeding, infertility, and preoperative control. Starting with the first pillar, pelvic pain, ultrasound is the immediate tool used to differentiate a life-threatening ectopic pregnancy from distinct ovarian pathologies. This scan shows the clear signature of a dermoid cyst, or teratoma. Notice the intense, bright white echogenicity that casts a shadow downward. That brightness is caused by solid components like fat, cartilage, and hair trapped inside the cyst. This rendering demonstrates how we identify issues in the fallopian tubes. This dilated, fluid-filled, sausage-shaped structure with incomplete internal walls is a classic presentation of a hydrosalpinx, a blocked, damaged tube often tied to chronic pelvic pain. The second diagnostic pillar is genital bleeding. In these cases, particularly for postmenopausal women, the entire assessment centers on a strict evaluation of the endometrium. This technical image highlights the critical threshold. For a postmenopausal patient, an endometrial thickness exceeding 4 millimeters requires immediate investigation. Here, the measurement is 15 millimeters, which strongly raises the suspicion for endometrial hyperplasia or carcinoma. To get a clearer view of the uterine cavity, we use sonohysterography. As you can see in this scan, infusing the uterus with sterile saline pushes the walls apart, clearly outlining an intracavitary polyp that was causing the bleeding. When patients arrive with acute pain or unexplained bleeding, sonography rapidly filters out the noise. It provides immediate structural clarity, instantly narrowing the differential diagnosis. The final 2 pillars, infertility and preoperative control, rely on ultrasound to track ovarian follicles during IVF and to map out complex congenital anomalies of the reproductive tract. This transverse scan reveals one of those congenital defects. We can clearly see 2 distinct endometrial cavities. This is a didelphys uterus, a structural anomaly that can be a major underlying factor in cases of recurrent pregnancy loss. But the ultimate gynecological diagnostic challenge is determining whether an ovarian mass is benign or malignant before taking a patient into surgery. Looking for structural red flags, this B-mode image shows a complex multilocular cyst. Thick internal walls and inward-growing papillary projections indicate potential malignancy. Applying power Doppler, bright red mapping reveals intense neovascularization inside the solid components. The tumor is building its blood supply. And this brings us to a definitive hemodynamic rule. Malignant tumors exhibit exceptionally low resistance to blood flow. Why? Because these rapidly forming new vessels lack a muscular layer, allowing blood to rush in unrestricted. Sonography functions as an indispensable extension of the clinical exam, providing the non-invasive hemodynamic proof required to dictate surgical outcomes.